friends. So today we'll be discussing with histamines and antihistamines. That is, we are starting a new system, autocoids. Okay. So what is meant by autocoids? Auto means self, and echoes means healing substance or remedy. So these are also known as local hormones, the substances that are produced locally that bring about the action. So you have different types of autocoids. We have amine derivatives, that is your histamine and serotonin. Peptide derivatives, that is bradykinin, angiotensin, kallidin. Lipid derivatives like prostaglandins, leukotrienes, platelet activator factor, etc. So this class will concentrate on histamine and antihistamine. So what is histamine synthesis, storage and metabolism? Histamine, where do we think histamine is synthesized from? Histose means tissue. Okay. So histamine is synthesized by decarboxylation of histidine. And where is it stored? You all know it is stored in mast cells. That is a chief site of storage. There are certain non-mast cell sites where histamine is stored, that is epidermis, gastric mucosa and in CNS. So this is a mast cell where histamine is stored. And this is histamine derived from histidine with the action of histidine decarboxylase enzyme. Now, what are the main receptors on which histamine acts? Acts on H1, H2, H3, H4. H1, H2 is the ones which we are mainly concerned. H1 mediates allergy, inflammation, because of which we all know antihistamines are classically the antihistamines term is for H1 antihistamines, right? So we use it for different allergic conditions, okay? So it mediates allergy, inflammation, bronchoconstriction, and maintains wakefulness. And the one agonist, that is H1 agonist, is beta histamine, which we use for vertigo in Meniere's disease. We have heard about Vertin tablet and all is H1 antihistamine and H1 agonist. Okay, the antagonist is cetirizine, which we use for allergies. Next one is H2, which we have done in detail in when we cover the peptic ulcer. H2 is mainly involved in gastric acid secretion. Okay, so antagonist is ranitidine, famotidine, which we use for peptic ulcer. For completion's sake, we'll see what does H3 receptor do and H4 receptor do. H3 receptor is a presynaptic receptor, just like a brake. H3 inhibits the release of histamine. An inverse agonist of this, that is, or otherwise known as an antagonist, that is tiprolizant, otherwise known as pitolisant, is used for narcolepsy. Okay, to maintain the wakefulness, we can use this agent. H4, not much of a clinical role. It is present on eosinophils, basophils, and mast cells and promotes the chemotaxis. So clinically, more important ones are H1 and H2 blockers. When we talk about antihistamines, we are talking about H1 blockers. Okay. What are the actions of histamine? So we say it is present on mast cells. So when there is an antigen, there is an allergic reaction, the mast cell releases the histamine. They go and act on different systems. Gastric acid, what does it do? It enhances the gastric acid secretion by acting on H2 receptors. What does it do to the blood vessels? It causes vasodilatation. By acting on H1 receptors, early response by release of nitric oxide. By acting on H2, it produces delayed response by acting directly on the smooth muscles. And capillary permeability is also increased. That results in erythema and edema. Okay. And on the bronchus, it causes bronchoconstriction by acting on the H1 receptors, and by acting on the peripheral nerve endings, it can cause itching. So when there is an anaphylaxis, what happens? There is massive release of histamine that causes bronchospasm. The patient will have difficulty in breathing, can cause rashes and itching because of sensitization of this nerve endings. It can cause hypotension because of action on H1 as well as H2 receptors. In the brain, histamine H1 is mainly involved in maintaining wakefulness, and that is the reason when we give H1 antagonist, the patient can get sedation as a side effect. Now, there are certain drugs that can release histamine liberators, okay, and these are can produce anaphylactoid reaction. The common drugs that can release histamine are D-tubocurarin, which is a skeletal muscle relaxant, morphine, atropine, pentamidine, polymyxin B, vancomycin. We've heard about red man syndrome and all. Okay. So these are all because of the histamine liberating property of these drugs. They call us histamine releasers. Now we come to antihistamine. So we briefly looked upon histamine, the receptors H1, H2, H3, H4. What are its actions? Actions of histamine. And then now we'll cover antihistamines. That is those which block the receptors, H1 receptors. Okay. So these are conventionally we say it as H1 receptor antagonists. They're competitive antagonists. We divide them into first generation and second generation. And H2 receptor blockers are antipeptic ulcer agents, that is your ranitidine, famotidine and all. So that we have covered under peptic ulcer chapter. So now we'll concentrate on H1 blockers. The first generation, what are the examples? Diphenhydramine, promethazine, doxepin, which are highly selective. Then we have moderately sedative agents like phenyramine, cyproheptadine, cinnarizine, and mild sedative is chlorpheniramine, clemastine, cyclizine and all. So these are first generation antihistamines. Then we have second generation antihistamines where you come to fexofenadine, cetirizine, loratadine, azilastine, all are second generation antihistamines. What was the problem with first generation antihistamines? First generation antihistamines, they can cause the blood-brain barrier. The sedation and psychomotor impairment is the main problem with the first generation. We know that even based on the sedation, they are divided into highly sedative, moderately sedative, and mild sedative. So sedation is the main problem of H1 antihistamines, the first generation antihistamines. So it should not be given in patients who require constant attention like truck drivers, machinery operators, swimmers. The first generation antihistamine should not be given for treatment of allergic conditions. Or if you're giving, you should advise them not to get involved in those activities while they are on this drug. And another property of this first generation antihistamines is they have got additional anticholinergic activity. So what all property will they have? Think about atropine, which is a classical anticholinergic drug. So it can cause dryness of the mouth, dryness of the secretions. Okay. So what are the uses of first generation antihistamines? Based on its H1 blocking property, we use it for allergic conditions like itching, urticaria, hay fever, insect bite, IV poisoning. Then, based on the central anticholinergic property, where do we use? We use it in Parkinsonism. Parkinsonism is a condition where there is an imbalance between dopamine and acetylcholine. There is a deficiency of dopamine and an excess of acetylcholine. Okay, so what we can do is we can either try to give dopamine agonists like levodopa or bromocriptine, different dopamine agonists we can give. Okay, or drugs which inhibit the dopamine metabolism like COMT inhibitors, MAO inhibitors and all can be given. Other method is you decrease the acetylcholine level. That is by giving central anticholinergic drugs. One drug which has a central anticholinergic property is your first generation antihistamines. Okay. Similarly, in acute muscular dystonia, again, when this is a condition which is usually drug induced, when we give D2 blockers like haloperidol, which is a drug that we give for schizophrenia, the blocking of D2 can result in Parkinsonism or in muscle dystonias. Treatment is again central anticholinergic drugs. Again, we can use H1 antihistamines with additional anticholinergic property. Common cold, prophylaxis of motion sickness, again by blocking the cholinergic pathway to the vomiting center. What are the adverse effects? As you all know, sedation is the most common adverse effect. There can be diminished alertness and concentration, lightheadedness, motor incoordination. Because of the anticholinergic effect, dryness of mouth, blurred vision, urinary hesitancy can be there. Now we come to the second generation antihistamines. What are the main advantage? Basically, they are more specific, less CNS side effects. They do not cause sedation. They do not have much of an anticholinergic effects, less drug interactions compared with the first generation. So basically we can use it for cold conditions. The use is restricted to anti-allergic effects. Now terfenadine, there are three drugs that you should remember. CAT drugs we say CAT, that is cisapride, terfenadine and astimazole. Okay, so the cisapride is a prokinetic agent. Terfenadine, astimazole are antihistamines. What is the importance of these drugs? This has been banned. Okay, they block delayed rectifier potassium channels. As a result, they produce ECG changes. They prolongs the QT interval and produces a condition known as torsade pointus. Okay, it is like a wave. ECG will look like a wave pattern that results in ventricular arrhythmias and patient can go into sudden death. This is especially when you use it with an enzyme inhibitor like ketoconazole or erythromycin. It can increase the concentration of these drugs that can lead to this ECG variation. So both terfenadine as well as astimazole possess this arrhythmogenic property, because of which, so this is how the ECG looks like when there is a toxicity of this terfenadine or cisapride or astimazole, because of which these drugs has been banned in 2011. Now coming to the newer agents like fexofenadine, it is a metabolite of terfenadine, but it does not lack or it does not have this potassium channel blocking property. Loratadine, again a newer agent that is longer acting because it is metabolized to desloratadine. Cetirizine, as we all know, commonly very widely used. The additional action is it inhibits the release of histamine and cytotoxic mediators from platelets as well as eosinophilic chemotaxis. So additional anti-allergic mechanisms are there. The active enantiomer is levocetirizine. Azelastine is an antihistamine with maximum topical activity. We use it as a nasal spray for allergic rhinitis. Olapatadine, recently approved topical agent, again used as a seasonal, used for seasonal allergic rhinitis as a nasal spray. Alcaftadine, approved as an ophthalmic solution for allergic conjunctivitis. These are the other agents: rupatadine, mesolastin, avastin, levocobastin, acrivistin. So these are all newer second generation antihistamines. And all these antihistamines, second generation antihistamines, are metabolized to active metabolite except cetirizine and mesolastin. So that is regarding histamines and antihistamines. So we have discussed what are the generally what is meant by autocoids. Then we learned about histamine, the receptors histamine acts on, what are the actions of histamine. Then regarding antihistamines, mainly H1 blockers we have discussed, because H2 blockers we are dealing in peptic ulcer. H1 blockers we have two generations. The first generation, main problem is a sedation, and they are mainly used for allergic conditions. So because of the sedation property, we should not use it in truck drivers or those who require severe concentration in their working, like machinery operators or swimmers and all. Plus additional activities there, anticholinergic property, because of which we use it in conditions like Parkinsonism, drug-induced Parkinsonism, drug-induced acute muscle dystonias, motion sickness, and all other additional uses of first generation antihistamine. The second generation antihistamines, the main advantages, they lack the sedation, they have only anti-allergic property, and most of them are longer acting because they have got active metabolites also. Okay, so these are the main important points that you should stress on antihistamines. So hope you understood. Thank you for listening.